don't have a quorum right now, so I'm going to change the agenda a little bit until we get a quorum, because we can't pass a minute and so forth. So I will hold off on that. Let me get this thing. On the agenda, I'd like to remind you of the course of the state Government Ethics Act and the duty of every board member to avoid both conflict of interest and appearance of conflict. Does anyone have any conflict with the agenda? No. Hearing none, then do I have a motion that we accept the agenda as presented?
Accept. As in.
Second. Move second. Any questions? All those in favor say aye.
Aye.
We're going to move down to the budget, Jim, if you would please.
Well, good afternoon. On your iPad, you'll see the financial dashboard. This is reporting as of May 31st, 2013. 11 months of the fiscal year, 1 month to go. So we're fast approaching the end of our fiscal year and all the things that happen as a result of our year end. We're on track to meet our budget and to stay within our budget. And just to review quickly for you the parts of the three different areas. And we'll start with DSS. And if you look on your dashboard, you'll see overall, the black line represents where we are in the part of the fiscal year, and the bar graph represents where we actually are, and the mountains behind represent where we were last fiscal year. On the right-hand side, if you look at DSS overall, you'll see that there are two areas where we're over the budget year, and that's been consistent as we've looked at the last 6 months. That's both in community contracts, where we pay for futures, and we front the money for service providers to be able to provide the resources up front to their clients that they serve, and then capital that represents a parking lot purchase. Everything else is within the budget. As you look at the detail of the accounting units, you'll notice that aging services is above, significantly above. Remember, that's a contract, and we pay twice a year, so we pay Land of Sky to administer that contract for us. And then you'll see community contracts is the other one that's significantly over. Any questions about the DSS portion of the financial report?
Jim, just
Yes.
so I understand this.
Absolutely.
In the numbers, it says 100%, so it doesn't show that we're over in those categories. Is that a computer thing that when you get to 100, it stops?
No, it is confusing. The black line on the graphs.
I know, I see the graphs, but I'm trying to figure out why, if we're over, why hasn't the number changed on the?
We're over where we could be based on the percentage of fiscal year that we've gone through. So in other words, we're at about 92% of the fiscal year. So we've spent 100% of the budget for the fiscal year.
So do we stop at that point?
Yes, we do.
Okay, that's what
yes,
I'm.
yes, I'm sorry. Thank you. Yeah,
So
we're not
we
going
stop
to
spending. So we're technically next week we'll be at 100% according to the bar graph as well.
Hopefully. No higher than that. Hopefully no higher. That's
Okay,
correct.
thank you.
Thank you for that clarification. Any other questions? Then we'll go down to look at public health. See within public health, overall, we're within the budget, slightly above in salary and operating, and that's mainly because we're actually about 92.5% through the payrolls. About 92% through the fiscal year, 92.5% through the payrolls. You'll see in the other operating and contracts, we're well under, and those will remain there, and we anticipate meeting all of our obligations as well as staying under budget. The main thing that I would point out to you that's impacting that under contracts is the regional public health. As you remember, the state decommissioned the state lab that was in our budget, so that's why there have been no more expenditures in there. Under the clinical, you'll see that we're slightly over where we are in the budget, but that's typical, and that has a lot to do mainly with our salary costs, since we're above the salary for the point in time for the fiscal year. Everything else is on track. Any other questions about the health portion? Then we'll look down, scroll down to the Parks, Greenways, and Recreation, and you'll see again there, we're within our budgeted figures, and the only place that you see within the accounting units where we're above is in Lake Julian, and that represents some seasonal spending that we have. But again, as Don pointed out, we will not go over the 100% of the budget as we get to the end of the fiscal year. Happy to answer any questions about anything related to the finances for FY13. Just as a quick update about FY14, the commissioners approved a continuation budget this morning. So we'll be working under the same budget as this year for the first month until they approve the final budget that they anticipate to do hopefully by the middle of the month, and that's anticipating some legislative action on the Cultural and Recreation Authority. Thank you very much.
That brings us to what we're going to have most of the day is panel discussions, which we're looking forward to. So I'm going to let Mandy go ahead and introduce the setup.
It's probably not the most effective leadership strategy to do a panel for the board on a subject where the knowledge is relatively limited. But the truth is, specific to Affordable Care Act and how it's going to play out, the rules really aren't written in a lot of instances. But we felt like because it has such a significant impact on health and human services, we need to talk about what we do know and how we're planning for that as a health and human service system. Did make a decision as we began preparing to split the panel in half. So today you're really going to hear about kind of an overview, the impact on the health and human services system specifically, and then we're going to hear from CCNC. Tanya Gosnell is with us today. Jennifer's on vacation. To talk about their role in managing health care for Medicaid populations and give some examples of some of their work. Curtis Venable is in the back. He's going to be part of our panel, so he can feel free to jump in, although he too and his firm are trying to get handles on places where just rules aren't written. And then we'll come back and do the piece from the safety net involving the Minnie Jones Clinic and other safety net providers on what's our capacity as a community as we move forward, and also some of the legal issues. We're just going to talk about it today very narrowly around health and human services, and then the current CCNC involvement with that population. I'm going to ask Jim and Rob and Steve, and if you want to come on up, Tom, that's fine. I mean, y'all can sit here and or around there, because we're all going to jump in and answer questions because we've all been doing research and putting pieces together. We just want to make sure we give you the most accurate information possible. So we'll start. Well, you're going to, Steve will be up before you. Steve, you want to come up too? I'm going to talk about overviews. Steve's going to talk about some of the preparation within the system, and then we'll hear from CCNC. Feel free if you feel the need to jump in and do so. This is a day I'll take no offense if I'm wrong about something. I'm laying that out there. We really, as we began trying to put the pieces together, let me start first and tell you what's in front of you. You have a copy of my PowerPoint and Steve's if you want to take notes on that. We did a one-pager for you. Lisa's communication folks, thank them very much, and Melissa for working on all that too, about how individuals can get ready and what the links are if you want more information. The community care PowerPoint's also in front of you if you want to take notes as we move through it or ask questions. But one of the first things that we wanted to get a handle on is what does the public know about the Affordable Care Act? You know, drivers?
Yes, I am.
Come back there. I want to start by talking about just the facts related to that. The most recent Kaiser poll says half of Americans really don't know how they'll be impacted by the Affordable Care Act, and that 4 in 10 think it's been repealed, that it's not even applicable anymore, and that 6 in 10 among households with incomes of less than $30,000. So an even greater number of lower income folks think they're not going to be impacted by it. It was repealed or went away. And then 5 in 10 among younger Americans. And younger Americans, and we'll reference that several times in the presentation, are often referred to in the literature as the young invincibles. Those are the individuals we believe that the insurance markets will heavily recruit and educate because they need those healthy individuals to balance some of the lower income individuals who've not had access to care and bring more challenging health care to the risk management strategies. But that's important to us when you begin thinking about the outreach. Recent poll says we haven't moved a great deal from where we began. 35% have a favorable view, 40% an unfavorable view, and 24% of Americans really still don't know what they think about the Affordable Care Act. Where do people get their information? And you have this in front of you if you can't see it. Again, the greatest sources are conversations with friends and families. Newspapers, radios, or cable TV. What I would say to you, and share some of those statistics, is that those numbers are much lower for lower income folks. You see great disparity between awareness of information and where they're getting their information from folks with incomes lower than $30,000 a year. That's really important to us as we plan for how we do outreach and education and connect to those individuals. So that's important data to us in our planning process.
Where are they getting those other 30? Must be conversation.
30% of those with lower incomes say they've learned something about the Affordable Care Act through mass media. That compares to 48% of those with incomes greater than $90,000. So a much lower percentage of individuals with low income have turned to mass media for information. Similar gaps are seen between the insured and uninsured. 46% of insured have chatted with a family member or a friend about the law. 32% of the uninsured said they never talked to anybody about the law. I mean, they just have no information or haven't communicated with anybody about it and aren't aware about how it's going to impact them. That's really critical to us because our role is probably going to be very targeted on the outreach to those lower income individuals. What we hope to cover today, and again, Dr. McLean, you came in, so I want to say, we're not claiming to be experts on this subject. We're doing the best we can to.
I was just saying that 50% of people that don't understand it
are
are
on
actually
this panel. We're learning as we go, and that's why I'm encouraging them to jump in and offer clarity. We've spent a lot of time on this over the last year, and particularly over the last couple of months. What we want to cover today is Medicaid expansion. North Carolina opted out. What does that really mean in terms of numbers of access for individuals? Who are the uninsured? What do they really look like? Who are they? What are the coverage mandates and penalties for people who don't get coverage? How the insurance marketplace is going to work, and other policy implications. So that's what we hope to cover today. The slide in front of you compares with and without Medicaid expansion. So the red line is projected growth for us through fiscal year 14 without Medicaid expansion. That's about looking at economic factors, our current rate of growth, and it also factors in, it does not factor in woodwork. It does. This one does, the next one does, woodwork. Woodwork are about almost 1,700 individuals that we believe are currently eligible for Medicaid but don't know it, or have chosen not to apply, but when they go into the marketplace to buy insurance, they'll be forced into an application and into the Medicaid screening process. And what that means is we'll likely see them come in the doors at DSS, or probably not come in the doors, but we'll get their application through technology. That's an important number. A component that did not get much attention to begin with, but is getting more and more attention, is that while many individuals who go into the marketplace may not be Medicaid eligible, they may be eligible for other human service programs and didn't know it, and because the marketplace will give them a link to EPASS, our eligibility system, they're basically saying, particularly in urban areas, and we'll go into some of that data in a little while, and particularly in any healthcare hubs, you're going to see growth across all programs because people who weren't aware they were eligible for any programs will become aware of that. The blue line is had North Carolina made a decision to expand in Medicaid in FY14. Most of the numbers, they jump all over the board, but the most consistent number we've heard about how that would affect us is almost 12,000 additional adults would have gone to Medicaid. Want to talk about who are the uninsured, and this is looking at North Carolina data. About 16% of them are unemployed, 13% work part-time, 45% have at least one full-time worker in their home, and 26% have two full-time workers in their home. We think people have a misconception about who's uninsured. We also think if you look at our economy, we probably have a higher percentage of individuals who work without insurance because of the tourism aspect of our economy, too. Who are the uninsured? Again, looking at this, and this is important again by in terms of outreach and education. If you look at it by demographics, you have 48% who are white, 28% who are black, 19% who are Hispanic, and 6% who are not white, black, or Hispanic. And why that's important is how we do outreach really differs depending on those demographics. So 84% of the uninsured in North Carolina are in families where at least one person works full-time. I'm not sure that that fits with most people's perception of who are uninsured. We really, and I'm going to talk through this, but we really wanted to try to boil down a number of individuals who are impacted by North Carolina's decision not to expand and who will likely be eligible for subsidies or assistance with private insurance in the marketplace and how we prepare for that. And that's what this slide does. And I think we're all in agreement if you look at the first slide, which are individuals 0 to 17, that we have a very robust outreach program for children related to Medicaid and health choice. I think we believe, and Curtis, correct me if I'm wrong, I think Minnie Jones believes you have a lot of undocumented aliens who aren't eligible in there. But that's probably the bulk of that 1,500 number, although we do want to make sure we continue to push for children who may be eligible for Medicaid, getting connected to Medicaid. Then your 18 to 64-year-olds, which is where we really want to focus. Your 65 plus, are people who should be being connected somewhere in the Medicare system, with few exceptions. And I will say, since Minnie Jones is the largest safety net provider, their policies require people to push into the Medicare system if they come in for services and they're not yet connected. So that's less the group we worry about. So a simpler slide that takes you down to the number of adults we really want to wrap our hands around is about 4,260. What I'd say to you is, this slide is the one that does not include the woodwork. So you take out that number and you think about uninsured individuals who are being served somewhere other than the Minnie Jones Clinic, and Minnie Mayhack serves a great number of those. We think you get closer to a number of somewhere between 3,000 and 4,000 individuals who are going to go into the marketplace, be eligible for some subsidies, that we need to plan for as a community. How do we reach those individuals? How do we support their access to what's available to them under the Affordable Care Act? And those are uninsured in Buncombe County under 100% of federal poverty. And you all, people in this room, know this better than we know this. Why does insurance matter for individuals? What we know is that if you look at social deterrence as a whole, they're less likely to suffer in other areas financially, 25% less likely to have an unpaid bill being sent to a collection agent, 40% less likely to borrow money or fail to pay other bills. So people who have insurance tend to be people who are better able to meet basic needs for themselves and their families. And the national number is $18 billion in savings for individuals who go to an emergency department who could be served at a different level of care. And what we know is people with insurance have better health outcomes. 55% more likely to see a doctor, 20% more likely to say their health is good or excellent, and 40% less likely to say their health has gotten worse over the last year. One of the interesting statistics that I didn't hit on that first page, Rob, if you look back on, is the number of individuals who are uninsured, who currently say their health is good. That was high.
It was 87.2.
87.2% of the people who are currently not covered in the United States say my health is good or excellent.
That's actually in C.
Is that North Carolina?
Yeah.
Okay. I'm telling you, we're gonna jump on each other. We've been round and round hammering these numbers down.
Did that have an age attached to it? I mean, what age group was that, that said my health is good, I have no insurance? Was that 18 to?
That was,
It might have had that broken down by age, but I don't have that on right now.
we'll get it, send it to you.
Okay.
We'll send you any of the source documents for any of this.
I was just sitting here thinking that we've just, I understand the legislature's just passed the new payday lending bill to allow folks to get some help with this.
That is one of the greater.
Thank you for laughing. You know, I'm always afraid, Doctor. Some of
Creative
my
solutions,
jokes
creative solutions.
won't go over well.
You want this on, Lisa?
Ready? Are we good?
Yeah, okay. Talk about the mandate and the tax penalty beginning in January of 2014. Those without insurance may have to pay a fee, 1% of their income or $95 per adult, whichever is the higher, would be the penalty beginning there. Beginning in January of 2016, those without insurance will have to pay a higher fee, which for penalty, which would be 2.5% of their income, or $695 per adult. That's a steep amount. Exclusions are those who don't file a tax, who don't have to file an income tax return. People with financial hardships, although that's a place, and Curtis, you feel free to correct me if I'm wrong, we can't find much hard rules about what defines a financial hardship. So that'll be interesting to navigate through. Religious objections, those who've been without coverage for less than 3 months, members of tribes, illegal immigrants, and those whose premium cost would exceed a specific share of their income. Again, that's one of those things that begins at 8% in 2014 and escalates through the index over time.
How is religious objections defined?
Yeah. How they?
That will be interesting to see. I would imagine it's mean the same things Gibby faces around individuals who say they're not going to comply with mandated immunizations. Because
Right, and all you have to do there is just say, I don't
I
vaccinate
think it
because
would be,
it's against my
do you
religion.
know what, Curtis, it'll be a statement of self-declaration. I don't know what else you can do. Now, see, there you go, even the lawyers are going.
I mean, it seems to me that would be a great loophole like it is.
I think it's a huge loophole.
I think the difference with that and the immunization exemption is those are determined on a state-by-state basis, and this is the federal.
This is federal. That's a really good point, which will make it even harder. And there really is no defined way on how penalties would be captured anyway. I mean, the IRS has taken a pretty hard stance. That's way down on their priority list. And one of the challenges we know are as you do bring up, very few of these individuals have checking accounts or the capacity to have that drafted. Who pays the penalty? And this is just giving you a look. We won't go into a lot of detail about that. But if you look, you know, what's important to know is they're anticipated to be about 5.9 million projected payers of the penalty. And that would generate about $6.9 billion in penalty revenue. The largest percentage of those who are projected to pay a penalty are those greater than 500% of federal poverty. The greatest share of where those revenues will come from, though, if you'll notice, 21% are the 100 to 200% of poverty, the lowest income individuals. You can jump in. I swear, Rob, it's okay to correct.
No, it's okay. The graphs are
Yeah.
backwards. So the 55% of the revenue comes from the greater than 500% of poverty, but the payers, so that's the payers, that's the revenue.
Yes.
It got flipped.
It got flipped. Yeah.
Oh, it got
Yeah.
okay. The insurance marketplace, and we're just going to we're going to go to those hyperlinks for a minute to show you what it looks like and show you very briefly what summary the federal government has put out for individuals. I love this video.
Find health insurance at the Health Insurance Marketplace. It's an online shopping site.
Shop for health insurance that fits you with low cost and even zero.
Like the home insurance.
Uninsured. For better coverage, you can see your options all in one place. One application. It's a place to compare a wide range of quality health insurance plans, to review them all side by side, and choose the one that's right for you.
Easy to understand. You'll explore the marketplace at your own pace. You can compare prices and benefits. See an explanation of what a premium is and what a plan will cost you every month before you make a choice. And every plan will cover you with comprehensive benefits, from your visits to the doctor or the hospital to your prescriptions, to screenings for cancer and other conditions. And no plan can turn you away even if you already have an illness or condition. The Health Insurance Marketplace, part of the healthcare law, opening October 1st. You can learn more right here, right now, and be ready for the new world of health insurance shopping benefits, from your visits to the doctor or the hospital to your prescriptions, to screenings for cancer and other conditions. And no plan can turn you away even if you already have an illness or condition. The Health Insurance Marketplace, part of the healthcare law, opening October 1st. You can learn more right here, right now, and be ready for the new world of health insurance shopping.
Sorry about that. You want us to, I think the point is to get it.
That's kind
She
of
has fine looking legs too, doesn't she?
And then we really wanted to click on and actually show you what an individual who goes to the marketplace, if you go down to the next. This is actually, and this has been revised as recently as this week. This is actually what it'll look like for an individual who goes to the marketplace, where they'll hit the start now. Ask them if they're looking as an individual or as an employee, and it'll walk them through their options, much like Medicare Part B. Where they enter their health information and talk about which state they're in, make choices about their insurance online. Part of what Steve will talk about in a little while is we are anticipating that many of those individuals will need assistance navigating those systems. And so that's a part of what we want to talk about in terms of how we move forward, and we're also anticipating that as a community, one of the things we may want to look at is from a business case perspective, is there a population where it makes sense for us to look at a structure that assists with those premiums, so those individuals do have access to insurance and don't continue to cycle in and out of the emergency department, and be a cost burden on the overall public system in different ways. That's a part of what we'll be looking at. Oh, it's just been that day.
It has, it's been a week actually.
One of the things we thought people would be interested in is how much will subsidies be. So Rob did two examples for us. One is a single adult who's a non-smoker. And Rob, remind us what the premium is for smoking.
Yeah, there's a surcharge per individual who smokes that's about $1,700 on group premium.
But in North Carolina, we cannot call it a surcharge. It is a benefit to those that don't smoke. Sorry.
It's all in the messaging, right, Stephanie?
There's basically what we did on this chart was look at federal poverty levels between 100 and 400%. We told you what that meant in terms of income, so people had some framework for what individuals would fall into each of those categories, what their estimated premiums would be, and the approximate subsidy under each of those, and what they might actually pay. So an individual under 100% of federal poverty, earning about $11,490 of income, would have an estimated premium of $3,400, get a subsidy of $3,196, and they would actually pay about $230 or 2% of their income. can see when you get up to 400%, a single adult would be eligible for a subsidy. So they would pay a premium of $3,400 a year. I think one of the things interesting about that slide, Curtis, is I think Carlos, long before much detail was out, estimated about $200 for individuals below 100%. He's pretty dead on about that.
That's a year or a month? A year?
That's a year. But, I mean, I would tell you, I think if you look for individuals not currently planning for those expenditures, some of these numbers are fairly significant for them. Yeah, Rob also did us an example.
Are we go, just so you can see that you can go and figure out what for any individual.
Yes,
yeah,
there's a subsidy calculator on that website, which is, y'all have the link in the materials. So if you wanted to run some scenarios, you could do that for individuals so they understood what their subsidy might be. And Rob, that's actually how you can open your numbers, is running through that calculator.
So it's approximate.
Yeah.
It's based on the silver plan.
2 adults and 1 child. Again, non-smokers, you see that subsidy at below 100% of federal poverty is about, what they'd actually pay for insurance, about $391 a year. When you get to a family of 3 at 400% of federal poverty, they'd actually pay about $7,400 a year. One thing that's important to know is that the subsidy can only be applied, you all have in front of you, there are levels of insurance plans in the federal law from silver to bronze to platinum. You can only apply the subsidy at the from the point of the second lowest silver plan in your state plan. So once we know who the insurance companies are going to be and they put their plans out there in North Carolina, subsidies can only be applied to the second lowest in the silver category. Otherwise, you can't have a subsidy. So there's not a lot of choice about the extent of the coverage. What has to be in every one of those marketplace plans, that's the list of services. There are some well services and preventive services, which is a positive thing, chronic disease management, and many of the others are pretty standard for insurance. But those are the things that
And is
you
the
know.
percentage, or you say covered, what does it cover?
It does not give you that level of detail.
So, okay.
You'd be choosing it, much like if any of y'all have done Medicare Part B with parents, you'd be choosing levels of coverage.
Right.
How high you want your can afford a deductible or a copay.
Has the federal government come out yet, HHS, with definitions of what these words mean?
There are some definitions which we're happy to send to you. They are very generic, very generic. One of the things, and this is the timeline, the federal government says that they are on target for opening the health insurance marketplace. You begin to see some of those strategies come forward this week. You saw the White House announce a partnership around Hispanic community and outreach to the Hispanic population. Signed an agreement with the NFL to help them do recruitment in the invincible young population. It's a pretty good strategy, I thought. This is their timeline, and you actually see that the timeline now says there'll be open enrollment, and people will begin enrolling between October and March is the enrollment. Where can people go for assistance navigate in terms of navigating the system? North Carolina has put forward a grant application to the federal government for a consortium of navigators that includes North Carolina Legal Services, the Benefit Bank, North Carolina Medical Assistance, some CCNCs, not all CCNCs, our Council on Aging in Buncombe County, and the Cooperative Extension. As you can see, some of those partners are saying in their proposal they would focus on a very specific population. Cooperative Extension says our focus is on people who live in rural communities. So people are focusing on different components of that. FQHC's also received federal money to do navigation specific to some of the populations that they serve. What role will we have? the belief that many of these people, particularly at the lower end of the income scale, are people who already come in our doors, already apply, primarily anymore, they don't come in our door, they apply electronically. The requirement in the Affordable Care Act for no wrong door, and we have a lot of IT folks here today, I can't emphasize enough the requirement on us that people can access all of our services electronically. That your ability to get to a building cannot be a deterrent to access, and that we have a responsibility to ensure that the public has real-time updated information. We can't live in the old days where you needed to update your website, you sent it through a group to have that process. It means it has to be updated for us legally in the morning if there's something people need to have in terms of that timeline. And then how we focus on outreach and communication planning are the big components for us. And I think Steve's going to jump in at this point.
Just want to reiterate a point on this for us, as far as the role we're making, that we play in what's going on with the Affordable Care Act. I think one of the things that we think that the consumers are going to see is that there's a direct correlation between what they see that's going on with the Affordable Care Act and the services that we're already providing, so that we know that many of those folks will be coming through our door. So for us right now, obviously communication planning and analyzing our internal operations, that's going to be key to effectively assisting the insurance marketplace walk-ins and the callers. As you can see from the 2013 Navigator service coverage map, Buncombe County, we're fortunate that we have a good contingency of potential consortium members. Of the uninsured in Buncombe County, approximately 1,700 are currently eligible for Medicaid. That's the word work eligibles that Mandy mentioned. We're anticipating working with those folks in a more direct manner. Another residual effect is that we may see other consumers come through the doors or electronically or in person may qualify for other human service programs, including the food nutrition services. So that would work effect to focus those.
Before Steve leads that slide, I'll just tell you the big orange dots of which were one. It's projected that 89% of the individuals that will be impacted in access services sit in those urban counties. So even though you see those little dots other places, they really have their impact will be much smaller. The feds have also clearly said to North Carolina as we moved into this that your 100 county lines mean nothing to us. The individual has the right to apply for Medicaid in North Carolina. County lines and county residency around Medicaid will become less and less of an issue as we move forward.
What have we done to position ourselves for these for the imminent changes that we're going through? Just to tell you a little bit about a lot of things that really have been in place already for Buncombe County that through Mandy's vision and Health and Human Services. We already have a unified front desk and call center to serve the Buncombe residents. And that's not only for their economic service program needs, but also for the health needs that we have at 40 Cox Avenue. We also have added greeters to assist the consumers navigate their safety area and all of those various services that we offer. Those staff are cross-trained not only programmatically but functionally as well. We've made numerous technological advances to serve the consumers better as they come through the doors. We now utilize Northwoods. That's a document image management system. That's really allowed staff to go paperless, and then you can imagine the efficiencies that go with that. And staff are now using a program called QFlow. That's a seamless client routing system, and that's really helped us to reduce the consumer wait times. So what are we doing now to move forward? One of the things that we're working on right now is creating a self-service center. What that's going to be for us is having a separate room where we can have folks come in and use computers that are set up, and plus have assistance from a staff member to help walk them through any of the application processes that we have through ePass, and we'll talk about that just a little bit more in just a minute. We know that for a lot of folks that come through our doors, there's a certain level of anxiety they probably feel in having a face-to-face encounter, so we think for a lot of folks that they'll see this as a better option for them. I'm going to skip down to the NC Fast part right there. It says NC Fast rollout and talk about that first. One of the things that's really big and happening for economic services for the public assistance arena for Buncombe County and North Carolina, and really I say that because the changes that are going on in economic service right now are really unprecedented. We have more going on now than I think that we've ever had in the course of the last 20, 30 years. It's just really amazing. One of the big things that we're working on is moving to a full-service, automated, all-public assistance, single-source database system called NCFAST. In case anybody asks you, that stands for North Carolina Families Accessing Services Through Technology. NCFAST introduces new technological tools and business processes that really will enable our staff to spend less time on administrative tasks and more time assisting families. That's really what we're about, right? NCFAST Project 1 was the first stage that we went through last year. That involved rolling in all of the food nutrition service cases into the NCFAST system from the old web-based system we had called FSIS, which we've been using that same system for a couple of decades, right? It's an old black screen program. FNS staff have been operating in the NCFAST world for a year as of last week. So we celebrated 1 year of working in NCFAST. NCFAST Project 2 and 6, which is what we're getting ready to roll into, will involve putting all of our Medicaid and work first cases into the NCFAST system. After that, we have NCFAST Project 7, and that involves modifications needed to the NCFAST system to accommodate the ACA requirements. As you can imagine, having all 100 counties accessing a single web-based program that will house all of the public assistance cases, including, in the future, child care subsidies, the crisis intervention program, the emergency assistance program, the low-income energy assistance program. The demand will be pretty big on the state systems to be able to do this. And again, it's a web-based system. So obviously, as Mandy indicated, having efficient speed and system response times, that's really going to be critical to our operations so that we can ensure that first, that we are really able to be as efficient as we would like to be in the system as it's created, but also to ensure that our consumers, that they get their benefits in a timely and accurate fashion. Going back up to the ePass, really excited about this part of it. We're working on a communication plan to market and promote the idea of using ePass. It's an electronic pre-assessment screening service that's expected to interface with the insurance marketplace at some point. The advantage for this system, it's all web-based and basically means that our consumers can access applications for all the programs or one of the programs through one single portal at their leisure. They can do this at home, maybe in a library somewhere. And we really see a big opportunity here to work and expand more with our community partners. When you look at folks like ABCCM, Evelyn Charities, Manna Food Bank, and all the partners we work with on a regular basis, many of the medical facilities that we have, really see an opportunity that for a kiosk or a separate computer could be set up, and those folks could be served through that particular portal. Looking at the information you see there on the screen, 1,693 FNS applications. Those were submitted statewide just within a month, and that's really without much marketing of the fact that ePass is available. It's a pretty large number, so we're envisioning that that number will certainly increase as time goes by. Right now, it's not available for Medicaid. It is FNS, but that should be rolling in fairly soon. The next thing we're working on is, I don't think we have it on the screen there, but I'll talk about it more in just a few minutes. It's talking about universal worker model design and how that's tied to the state initiative for workforce strategies. So let me get into that in just a second. Before we do that, I want to show you the projected timeline the state had. This is a couple of months old. You can't see it at the top. It says schedule subject to change. And obviously it has changed some if you look at it. Looking at some of the more important dates up there, the pilot for the soft launch for what we call P2 and 6 is for Medicaid and Work First roll-in. That was supposed to occur in June. Looks like that's been pushed out to July 15th. And down at P7, P7 is about the Affordable Care Act and the insurance marketplace. That's the change discussion, guys. Certainly going to be valuable to us, but as of right now, it's in progress and will be coming out. The statewide soft launch, as they had indicated, was prior to August. For our county, we have settled on a date now for September 9th. Feel like that's pretty concrete. That's when Buncombe County will go into soft launch for P2 and 6 for NCFAST.
I really want to make the point, that means September 9th, Medicaid rolls out in NCFAST, and October 1st is open enrollment. So North Carolina's pushed, though, they really put us in a pretty tight schedule for transitioning those two systems.
Some of the counties are going in September 30th.
Yeah, yeah, that is true. Some are rolling out September. Are they doing hard launch?
I'm sorry, I'm having a little hard time keeping up. And I'm gonna embarrass myself. What's P2 and 6 and P7?
Yeah, P2 and 6 is, P1, we don't have a graphic for that. Project 1, that's for the
Project, okay, I'm
FNS
sorry.
rollout, that's my fault. And P2 and 6 is for Work First and Medicaid to go into NC Fast. Basically what we're gonna have to do is, the current system we're using is called EIS, Eligibility Information System. And it's an old black screen program as well, a Unix-based system. And all those cases will be converted and put over into NC Fast. Then at some point we'll go hard launch, which, well, the new cases will go in, then we'll convert those cases later. But eventually, the Medicaid and the Work First Family Assistance cases will all be rolled into NC Fast, the same program we're using for FNS right now. So that's what we refer to as P2 and 6. P7 is the Insurance Marketplace and Affordable Care Act modifications.
Gotcha. Thank you.
Chatham, Johnson, and Orange County are the first 3 counties that will go into that, so we'll certainly be watching those counties fairly closely. One thing that, I apologize for this, I didn't put a screenshot for this, but I wanted to just mention briefly about the NC Tracks. That's coming out, let's see, July
1st.
So you already know that.
We've all been locking in.
I'm going to pass around an email that I have that has information on here that I think it might be useful for you, or maybe some of the partners that you work with. Basically what it has on it is the call center number for NC Tracks. And let me explain what that is. Medicaid providers will switch to that from using a 35-year-old claims system that they had in place before. We're going to switch to this new database system, sort of similar, I guess, to NC Fast, called NC Tracks. So the HHS is anticipating a lot of calls and emails. So what they have done, they've set up a call center number and also a web page where you can get frequently asked questions, type information, training information, any of the latest updates that are coming up about NC Tracks. So with permission of the chairman, I want to pass this around for folks to get the information on it. You wouldn't care to just pass that through.
Hopefully if you're a provider, you've billed.
So what are we doing now to prepare? Currently, we're redesigning our operations at the 40 Cox Avenue office. Really, the goal is to be more efficiently in a place to be able to serve our consumers better. I've described many of the new innovations that we implemented in a previous slide, but we're continuing to make improvements that our staff have really been active to design, and that we're learning through a participation in a statewide initiative called the Work Support Strategies. That's made up of a consortium of county and state staff and a private firm that we're working with called PCG and many others. So through the Work Support Strategies, we are seeing some other things that we see as opportunities that we want to implement for Buncombe County. Just a quick vision statement for the Work Support Strategies. That particular consortium is centered around the tenants, numerous tenants, but 2 of the primary ones that really fit with the things that I think we already have in place that we continue to expand on is that families will tell their stories once and receive the services that they need. And there will be no long door for accessing services or benefits. Good thing about that is that customers will come through and be able to have choice in when and where and how they receive those benefits. As far as project, the NC Fast core team, one of the things that we've been really actively working on for the last 2 or 3 months to be more proactive instead of reactive toward the changes is created the NC Fast core team. That particular team is developed, taking in a lot of the internal talent that we have from senior management of economic services, but also some of the supervisors from the line. But the HISBs are involved as well, human service planner evaluators, and some other folks that are tied to that, specifically operations and IT. Really appreciate their involvement in that, to pull all the people to one table together at the same time. Christina McAtee, who was in the back, wave your hand. Christina is one of our human service planner evaluators that's right now our project manager for this, and she's really done a phenomenal job trying to help us keep this coordinated and organized. And just to kind of show you what she's been working on for us, I know that's a pretty good distance away from you, but you can just see how much we have on there as far as everything that's tied into everything that we're looking at for rollout for NC Fast, making sure that we're covering all our bases, and our project timeline. And looking through the list, she has all the things that we're working on as far as the titles, the start dates, end dates, percent of completion, in progress, and also who the owners and champions are, just as a way to ensure that we are meeting those goals and that we have all the right people in the right places to continue to move that forward. So really feel good about how that's moving forward with the comprehensive way that we're approaching it. And certainly appreciate Christina's involvement and working with us on this. Part of the things that we worked on was looking at a process redesign, how we work internally. One of the first things we did is realizing that within our own staffing levels, we have some folks that have varying degrees of strengths. And so what we wanted to do is try to look at creating teams that can work together to create efficiencies and certainly better serve the consumers. One of the things that we did was utilize a self-survey that staff could take, and also taking in supervisor and lead worker input to basically complete an assessment of what we have in relation to the staff assets and the skill sets that they have to ensure that we're best aligned to really help our consumers. As far as some of the other implications of things that are impacting part of the process that we have going through is aligning case heads and certification periods so that we're all certified on the same dates, which you can imagine will certainly create less churning as far as those consumers coming through, but also building some efficiencies for us as well. Using new data to make management decisions. We really want to make sure that we're following those trends, whether on a weekly, monthly, semi-annually basis, and continuing to make modifications as needed as we continue to move forward into this new world. And the creation of a change in triage unit. A lot of the work we think that we can accomplish as far as creating efficiencies is really focusing on specific areas of where a lot of the bulk of that work will be coming in at, and who are the right people for that job, and how do we accomplish it effectively. Other big thing that's going to really affect how we're operating will be the adopting of the new federal MAGI. That's the Modified Adjusted Gross Income Scale, which is really changing the dynamic of budgeting and how we determine eligibility. One of the things that's going to be a little bit of a bump for us to try to figure out how to navigate that, but we'll get through that, will be determining eligibility and how the NCFAS will work within that arena, because right now the MAGI budgeting is only going to be affecting the Medicaid programs, or most of those Medicaid programs. So FNS and Work First will continue to be looked at using, I guess, more traditional methods. Do you understand? Thank you very much.
I'm going to introduce Tondra Gosnell, who's here from CCNC. It's going to talk about your role in managing Medicaid populations and coordination of services.
Yeah, I'm a program manager with Community Care of Western North Carolina, and you all know Jennifer Way, who is a board member and conveniently on vacation. So she has volunteered me for this opportunity. And
she said she would toast us from the beach.
Right about now. Yeah, that's great. It's okay, perfect. I'll get you. I'm good. We're going to pull it out. So I can go ahead and get it started. But Community Care of Western North Carolina is one of the 14 networks of across the state of Community Care of North Carolina. So I use their PowerPoint slide just to make it all cohesive. But we are one of the 14. And so there's a map, and you can probably see it really well on your big slides, but you can see it covers every county in North Carolina. And we are covering 8 of the communities in the west, and they all center around Buncombe. So we're covering Madison, Yancey and Mitchell, McDowell, and then to the south, Henderson, Rutherford, and Pope. That's why we're here today, to talk to you a little bit more about specifically some of the things that we're doing in Buncombe. So what is a community care network? Well, our role, our major goal, is to improve the care of the Medicaid population in a community, and thereby also controlling cost for those folks. We really focus on a medical home model, simple concept that really relies on primary care providers to coordinate and focus, provide a medical home for an individual Medicaid recipient. We really look at a network model so that we're not just looking at the primary care homes, but we're also looking at specialty care and human services so that everyone has a stake in sort of supporting an individual Medicaid recipient for better health outcomes. And like I was saying, that community support is part of that as well. So it's not solely a medical model. We are a private-public partnership, so say that fast 3 times. We're a local 501c3 not-for-profit, and so our board is actually made up of community agencies, local physicians, who really drive how we do business in our community. We are focusing again on that medical home model, and to complement that, it's one of our core services is care management for the Medicaid recipients. And I'll go into a little bit more about that in just a moment. Like I said, community-based and physician-led. We look to provide resources to the primary care provider, because as I go into a little more detail about what a medical home means, I mean, it's pretty intensive what they have to provide for a Medicaid recipient. And we also want to make sure that we're linking back those community resources, because medical services alone does not give a patient or a Medicaid recipient everything that they need, and you're already aware of that. So I'm just going to briefly go over some of our initiatives that I think that you would be really interested in. The medical home that I mentioned, health check, care management, sort of our bread and butter service line, clinical pharmacy management, quality improvement, and HealthNet, which is a program for low-income uninsured adults. And there are several projects that sort of fall under that title as well. So medical home, much like I was just mentioning before, it is a single primary care provider and a patient. So a patient, how we term it, a Medicaid recipient, is chooses a medical home, chooses a medical provider, and that medical provider enrolls them in their practice, and they will actually receive a per member per month, the medical provider will, for providing this medical home for a patient, in addition to fee-for-service when they come in for medical visits. So as a medical home, they have to make sure that they are providing 24/7, not face-to-face coverage, but at least phone calls, availability. They are providing sick and preventative care, and they're really coordinating all the things around that patient's medical needs. You have a home. And community care supports, in many ways, this model, but one way we do that is providing care management for not only the recipient, but it's care management inside of the medical home. And so we can really be advocates for an individual patient with their primary care provider. We provide a good deal of information that maybe primary care hasn't had from hospital or from a home situation to really support that primary care provider in providing the medical home for a patient. Health Check is a really important program for you guys to know about. It covers 0 to 20, so 0 to 20 years of age, and it's really focusing on ensuring that that population has the preventive and well exams that they need. So we actually have Health Check coordinators who work with individual practices, who work with community agencies, who work with families to remind them, to promote that your 12-year-old has not had a well child exam and no immunizations in the last 3 years, please come back into the primary care office. So it's a big push for that preventive exams. And like I said, they definitely do outreach not only to the families, but they're working with medical providers too, so that in office, they can identify, well, we already know this population of our patients haven't been back in a while, so it's time for us to go ahead and start scheduling. Care management, like I was saying, is our bread and butter, one of our core services. Our largest sort of staff ratio are the care managers that we have on board. And they do a range of things for individual patients. And I've listed a couple of different terminologies that we've used to sort of identify when they might specialize in a certain area, but they do it all. We have folks who work transitionally. So when a patient is moving from, say, hospital back to home, or hospital to a skilled nursing facility, or to long-term care, it's that individual who's helping to make that transition about medications, what new medical equipment the person has to have. We are working with folks just around chronic conditions, so it's not always just a hospitalization, but in helping people manage diabetes and asthma so that hopefully we can prevent hospitalizations. We have care managers who specialize in working with just pregnant women, at-risk pregnant women, because of medical conditions or social economic issues that might make them more at risk for preterm birth. We have care managers who work just with children, especially children with developmental disabilities, special needs, and folks who specialize just in sort of the 0 to 5 population with special needs. And we also have care managers who are really specializing in behavioral health. To know a lot more about the behavioral health world, to help make that transition both between medical home and services they're getting in the behavioral health world, we have a care manager to do that. We work with a lot of folks. Our process for care management, I just wanted to sort of highlight that because there's some really important things that really in order to qualify as care management, these things have got to happen. It's crucial for better health outcomes for the patient. We emphasize, again, that provider, that medical home. So you had an emergency room visit, you need to go back to your medical provider to follow up on that and hopefully prevent another emergency room visit. We're looking at medication self-management. Do you know what you're taking, what you're supposed to be taking? Did you get them filled? Do you know how to take them? Some very important and critical things for our population. Empowering patients and caregivers for better self-management. They're going to be responsible for themselves, when the doors close at the medical office. So they need to be empowered and have better skills. Helping to avoid those unnecessary medical visits like hospitalizations. Like I was mentioning, better self-management, hopefully less service utilization. And ensuring medications and services that they need that they're getting. So increasing that access for better outcomes. Clinical pharmacy management is just a piece of our team, and it complements the care management portion very, very well. So we actually have 4 pharmacists on staff with community care, and they are doing that really higher level medication management piece that is critical. When we see folks, I'll use the example again, coming out of the hospital, they've had a medication change, they have several specialists, they have a primary care provider who knows what's happening with medications. And so our pharmacists can really do a comprehensive review. They can actually provide feedback back to primary care about the prescriptions they're writing, which is a great resource again for primary care to have a pharmacist backup. And certainly for our care managers. And again, they're also able to do patient education really well. So another piece of us supporting that medical home is quality improvement. And I think of what Steve was talking about in your reorganization for Health and Human Services, that we recognize not only for our own agency, but for individual practices, they need to be focusing on how they can improve efficiencies so that they have a greater capacity and how they can improve care for patients. And so we have a quality improvement team. We have an individual who on that team is our EHR specialist, electronic health record. They can help providers go into their health record, this great tool that they have, and help it to manage their patient population better. So we put a lot of information in there about lab results. Can we get information out that says we know our diabetics that aren't in control, and tell us who those people are so that we can bring them back in? I think about one example in particular that really stood out. It's a practice that we've recently worked with that did a great job of referring patients to having their labs drawn for an A1C level, so for diabetic testing. This is important to have. So they've been referring and referring and referring, but why is nobody getting the test? We do it in office, it makes no sense whatsoever. So our quality improvement team actually worked with those providers and recognized that literally how their patient flow, how they divided their practice meant that people just went straight to reception and never passed the lab. So they never got the lab that they needed. So that's one of the things that we're sort of helping practices. We're asking you to manage them. It can be a very needy population. How can we help you in practice so you can manage them better? I don't want to leave out HealthNet. Like I was mentioning, is our uninsured program. So we work mostly with the Medicaid population, but HealthNet is actually a program that we receive funding through the Office of Rural Health and Community Care so that we can serve low-income uninsured adults. We're talking 0 to 200% of federal poverty, 100 to 200% of federal poverty. Those folks that are not qualifying for Medicaid, and that might be having lower income, but they have no children in the home, so they won't qualify. And the purpose is to get them linked to services like winches, to ABCCM, to medication assistance programs, so that they will have better health outcomes. We work very specifically with Mission Hospital and have a program for ED diversion for those folks who are continuing to go back to the emergency room rather than to a primary care provider. And we're also working very closely with Western Highlands to identify those folks with high behavioral health needs who aren't accessing the system in the way that they need to, and providing care management for those folks. So I thought that was a really important piece too in this whole discussion. Also, another important piece in how we're supporting primary care and really paying attention to the system as a whole is using data to improve our outcomes. These are just a couple of examples of what kind of data we have and how we're using it, and there are many, many more. We have a provider portal. So in our work, we actually have access to all Medicaid claims, paid claims. That's pharmacy, that's durable medical equipment, that's people visiting specialists and medical homes. Did they go for the well child? Those kinds of things. And we've actually created a provider portal that allows providers, a primary care provider, to open up, see what their patient is doing, really in an attempt to better manage that person. So they can see that you haven't had a well exam, but you've been to the emergency room 3 times in the last 6 months. What do we need to do to improve your care, even access, so that you can get back in here and be seen in a more cost-effective and better manner? So from that, providers can actually see who's in the care team, so what specialist a patient is seeing. You can see their visit history, like I was mentioning, see what medications they are actually filling. That's really important. And see care alerts, which is a general report that might say an asthmatic patient has a prescription for a controller medication, but hasn't filled it in 6 months. So just an alert to the physician, you may want to consider education or counseling with this person about how they should appropriately take their medications. So a good resource for the providers.
Is there demographic data associated with that? So you could look, so I mean, are you looking at health disparities or anything like that, or even looking back at practice models if there are differences in outcomes?
You know, I believe that there's a lot of discussion at the state level about how we use that data in aggregate, and I'm not the expert on that. So it might be a good Jennifer question for later on, and we certainly can follow up with you. But it is a great wealth of information and can be mined for a lot of different ways. We also are getting data feeds from hospitals, and so Blue Ridge Hospital, McDowell Hospital, our regional hospitals are sending us data feeds to say, folks have appeared in the emergency room, we have a patient here in the hospital, so that we can attach care managers to them and sort of begin this whole process of transition. In addition to that, ADT feed, so this admission and discharge information from across the state is now available. So it's not just patients in our region, because you already know that people cross county lines all the time. And so they don't only go to Mission Hospital, they could go to any number of hospitals across the state. And so we also get an ADT feed that gives us real-time information about your person just entered Duke. So that again, we can help to make that transition when they do come back to our community. And we're using some of our data, and this might be something in terms of what you're talking about, to find out potentially preventable readmissions. So using predictive modeling based on this person's information and past utilization and diagnosis, can we predict who's going to sort of sort out and be our highest cost folks? And we think that we've done a really great job of identifying individuals who will more likely spend more than they should for their diagnosis. And that's what the potentially preventable readmission. So something in the neighborhood of maybe what you're talking about. We also are doing, and this is statewide, so it's not just locally, statewide, QMAP, so quality measures and feedback. And so once a year, auditors go out to every practice that's enrolled in our networks across the state, and it actually equals over 1,300 practices, and they do over 30,000 chart reviews. So every primary care provider that's linked in this network actually will have a sample of their charts pulled and reviewed around the Medicaid population to come up with quality information. How are you treating your asthmatics? How are you treating your folks with heart disease and diabetes? And so this larger picture can help us as a state and can help us as a region to identify quality improvements that we can do. And then it can, on a local, very practice-specific level, help practices realize that they can do a little better around the management and care for certain chronic conditions. So just a couple of ways that we can use data to improve patients' health outcomes. And really, that is sort of the end for me. If you have any questions, let me. Yes, ma'am.
First, is behavioral health the same as mental health?
Yes.
Okay, thanks. I've been a little bit familiar. I did not realize you were a public-private partnership. I actually thought you were a government program. So thank you for clearing that up for me. But I have read about the wonderful outcomes you've had, and thank you for that. But my question is, in light of what you just described, sounds a lot like Dr. Voss's editorial in today's paper. How is what they are promoting different from what you're doing?
Very good question.
I'm gonna call Jennifer.
Yeah, we're definitely going to call Jennifer in. I know that CCNC and us as local networks have contributed significantly to conversations about their planning. How it plays into ultimately the design for that program is really, it's above my pay grade and it's not up to me.
Okay.
But I, without a doubt, agree with what you're saying, that we really are working hard to make a network, a local network for the recipients here in our communities. We know our folks better, and so I think that we have a really strong case for continuing that model because of all the work that we've done over many years.
I would just say I sit on the board of the CCWNC here, and what Tonda isn't saying is that they really, one of their great strengths that they say in there is that they're physician-led, and that brings a tremendous level of buy-in for all of the work that they're doing and the quality initiatives to realize the improved health outcomes, as well as being able to save dollars in the Medicaid world. And literally through independent audits, billions of dollars across North Carolina have been saved as a result of the work that CCNC has done. So I think Dr. Voss is probably, I haven't read that editorial today, but very much has said before that model is a model that she admires and hopefully will be a strong player as we move forward in Medicaid reform in North Carolina.
Can I just further clarify on that? Because I had the same question, but the other part of this, how long has Community Care of North Carolina been in place as a model program?
If I'm not mistaken, we have at least 16 years
16
of
years.
those efforts, yeah.
In relation to a new program that's being proposed, I just find that of interest. Thank you.
Who are the other players in this arena, other than Community Care of North Carolina? Do you have competition?
We don't have anyone locally who's serving the Medicaid population. So I'm sure that there are other agencies, and I couldn't rattle off any names for you at this moment, that probably serve private insurance types.
And in one of your earlier, I don't remember which one it was, you said patients who were assigned to you. You used the word patients assigned to us. Who does the assigning? How do you get
So
your referrals?
we don't assign. So patients are assigned a medical home here at the Department of Social Services.
Social services does.
Social Services enrolls patients or assigns, and really that's based on patient choice and availability. So if a provider is accepting patients, then that's going to help them to move their choice. You have to choose someone, and they have to be accepting patients. And once they get assigned to a practice, they are also part of the network. Does that make a little more sense?
Yeah. So I guess I'm wondering, are there patients who aren't in your network?
There are certain folks who sit outside of the network.
Who are
folks
Medicaid recipients?
Who are Medicaid recipients.
Yeah, that's.
And so there has been a big push across the state to move more people towards that enrolled or assigned pool, but certain individuals may still sit outside of. And one would be, and they're still working on that, folks who have been with long-term care facilities. So often long-term care facilities have their own providers that come into that facility versus a patient coming out into a medical home. And so there's really been some work around that. Can we bring in, say, extended care physicians, who is a group that typically provides in our area that service for long-term care facilities? Can we bring them in as a medical home? So there are others that still sit outside.
This is very informative. Thank you.
I think a lot of attention gets paid to who's not in network. There's a lot of focus on who those individuals are and why.
So the only way they get in your network is when they're assigned to home. Like for instance, my mother who comes up and just goes to Emerald Ridge, when she goes to the hospital like she is now, Medicaid does not show up in your network.
We'd have to look her up. She doesn't, if she hasn't been assigned a
No, she
medical
just got
home,
the extended care. Okay, yeah, so that, I see. So there would be enough people.
then she's not gonna receive care management service.
Which is a big point of discussion, because a large portion of the Medicaid dollars are spent on that level of care, but it's not required.
Gotcha, yeah.
So if you're a public-private partnership, is it the county that is the public entity, the public part of that, or is it the state?
Well, we receive funding from state dollars.
Okay.
So we actually receive a per member per month for every enrolled patient.
And then you
in the
receive
pool.
referrals from the county?
And then people are enrolled by the county. Does that make sense? Okay.
Wow, this is quite informative. Thank you so much.
That's it. That's why we couldn't do the last two. It's a big issue.
I must say that it's good to know that we have some people that working on the understanding this act, and appreciative of the work, and I'm sure they'll keep us informed. Thank you all so much for your input. Before I get into the next thing, I'd like to insert the process that I had to leave out, and that has to do with the board minutes. We've had a chance, now we do have a forum, and we've had a chance to look at the minutes. Anyone want to move that we accept them as presented? I'd appreciate it.
So moved.
Been moved and seconded.
Second.
Any questions? All those in favor say aye.
Aye.
Thank you. That moves us to, Mandy, are you going to do the director's report, or at least you're
Excuse me.
going to do the whole thing?
I'm sorry.
I'm sorry, before we move on, Bill,
Yeah.
are we going to hear from Carlos Gomez next month? Why is he,
We just decided it was more information than we could do, so we're still gonna do the component around the safety net
Okay.
and around the legal briefing in a follow-up. One of the debates is, I think Krista's probably sent something out, is who's here in July.
Oh, okay.
But we did, is
So in a
definitely
future
gonna finish
agenda
that
item.
piece, absolutely.
Okay, thank you.
He would have loved to have come today.
All right,
He has a lot of strong opinions on this.
And I still have some questions about the impact on the county in terms of government funding to us, like the impact of I'm still unclear about the impact of the Medicaid expansion, not taking Medicaid expansion. And also, it looks like we're also going to be serving people outside the county.
Well,
And is there provision in the Affordable Care Act to compensate Buncombe County for that work?
From the federal government's perspective, counties don't have an eligibility role in Medicaid. States do. North Carolina is one of 11 states that are state supervised, county administered. So there is no state money in the eligibility component of Medicaid.
Okay.
So what that means is we will have to hire, if our numbers grow, we'll have to hire additional staff. The Affordable Care Act provides for a higher federal reimbursement. Right now it's a 50-50 county-federal split for North Carolina. It changes to a 75-25 split, although there is currently debate about whether states who did not expand, have access to that. We're pushing hard on that, but that will be a financial impact with time.
Is the state addressing any of this?
Well, one of our biggest challenges around eligibility programs or federal programs, to just say it in an honest way, is the state's got no skin in the game. It's the issue that Steve brings up about you count income in Medicaid. I can't remember how many ways, 80 different ways. And when you want to try to align those, the state who's the policymaker has no money in how efficiently we determine eligibility. There's a very large distance in North Carolina. So it's one of the big challenges Steve was talking about we face. Affordable Care Act says really it ought to be easier for people to get public assistance, and their certification periods ought to line up, income ought to get counted the same way, assets ought to get counted the same way. It's harder in a state like North Carolina to get the state focused on that. So there will be impact. There is no doubt there will be impact.
And is Buncombe County at the table with the state in talking about these things?
Yes, and state, particularly the 10 urban counties are at the table with the state because that's where the bulk of these individuals live and will access services.
And we're one of those?
And we are one of those. Yeah, we're like 7th largest of the 10. So, yes. But that's a very good question. There is impact without that on a county level. If you'll remember, the General Assembly and the county traded Halloween candy several years ago around Medicaid. The counties no longer pay anything for Medicaid service. So the cost of the delivery, if I go to a doctor and the cost of my care, counties don't have any financial obligation for Medicaid. Our cost is in determining the eligibility, the administrative side. But your question is dead on, where we do have cost. Buncombe's kind of rare among counties in that we invest so heavily in indigent health care. Most counties don't do that. So when people are Medicaid eligible and don't have access to Medicaid, then they're part of who we're trying to serve through the contract with the FQHC, or MAHEC's trying to serve, or many private providers still see many of their patients when they lose health care coverage. And that's a big deal.
Thank you.
But, okay. Lisa was just going to quickly show you the new web because, as I mentioned before, Affordable Care Act makes a requirement on us that people are able to access our services seamlessly in simple manners and through technology and real-time data. So Lisa's team's worked on redoing the website. Just wanted to show it to you real quickly because it relates to this. And then
I'll take just literally a minute of your time. This is, Ben Atkins was very instrumental in getting this done, and the county itself is actually going to a new web design and format. This is the year coming up that we redo everything. So what we were trying to do right now was just make sure that our website reflected the fact that we had integrated. So toward that end, what we do is we have over here the actual different departments, starting with Parks, Greenways, and Rec, Public Assistance, Public Health, Social Work Services, and Veterans Assistance. And what we were trying to do is just go for a very clean, functional aspect for the website at this point. We hope as we grow in the communication team to really be developing other media outreach, social media, as well as with the new enhanced format, potentially doing other things. But we can see podcasts coming on here, YouTube videos, and things that would really help people. For example, with the Affordable Care Act, we're going to be doing some screenshots about it in an introductory YouTube where we'll say, confused about Affordable Care Act, we're here to help you and then guide them with screenshots going to the federal website so that they can do that easily and seamlessly. So you can click on any, so this is the main web page for Health and Human Services. On this right here, this goes back and forth, but you can actually click on this and immediately go and take a customer service survey to tell us how we're doing with our different programs, which we want to make sure, and that's in Spanish and Russian. It asks you first off what your first language is. I just had a little bit. Anyway, then the other thing you can do is we have a clean look so that there's no confusion about reporting abuse and neglect there on the right-hand side. We'll have updated stories, which is pretty standard for any other kind of web page, and then the e-pass system, which Steve referred to earlier, is right there and easily linked, and then the contact information. You guys are on here, just so you know, the boards and commissions, and your appointments. So that is on the web page. So people
But not our telephone numbers.
Not the telephone number, but people can reach you if they want to give you input to bring to the board.
Is that Bill's picture?
We just have your home address. So most of the pages are set up exactly the same, but again, what we want to just do is we don't want people searching for our services. We wanted to make it just very easy. So you can click on any number one of these things and then it takes you to another page where you get more detailed information. But we encourage you to go to the website. It's just buncombecounty.org. Go to the county departments and you'll see Health and Human Services, and give us any kind of feedback you have about what we should or shouldn't be having on there, as well as if you know of a resource in the community that you think is helpful that should be on the website, please contact me and I'll make sure that we get it up there as quickly as possible. So we encourage your feedback on this and also your input about content. So
It's a part of our preparing for Affordable Care Act. Jerry did.
Yeah, I know. Lisa, that's great work.
Yes.
That's really going to be
and the department heads are very instrumental.
yes. Jerry, you've got 1 minute.
Now, Bill, you took it away from me last time. I reminded you I'd be back. Thank you, Mr. Chairman, members of the board. Pleasure to be back. I always love this committee because you get to talk about substance. You go to the commission meeting, you hear it's a bunch of BS, to put it bluntly. And anyway, got some things that I think is going to be a visual effect on y'all, and you need to be aware of it. Last night at Smoky Mountain Center meeting, I made them aware that they didn't have anything on public information on their website. One gentleman so happily said, let's make this thing public and put all of our information out there. They didn't have a one year-end report on their website, and that was because I complained 2 months ago. So now everything, committee, everything is going to be on their website, and you're going to have access to it. And I think that's going to be really helpful for us in Buncombe County. Here's the other thing that I think is going to happen, and it's going to affect the medical home community. It's going to affect everything that we do here in Buncombe County. Every MCO in Buncombe County, anywhere else, has always said, we are getting cut. We ain't got no money. Every time you turn around, the state's doing this to us, right? Okay. We get to the MCO Finance Committee meeting, and oh my God, I had to scratch my head. $24 million in their fund balance at Smoky Mountain. At the one in Piedmont Behavioral Health, they got over 40 million. Now, I said, you don't get this kind of fund balance without cutting services. But one day, you're going to scratch your head, and maybe more, because the state's going to come after what you've been sticking back in fund balance because you've not been providing services to the community. Now, they mentioned two things, two big insurance companies, and the CEO said, one of them is state funds, the other is Medicaid funds. And he used insurance terminology. Now, what's going to happen to this? Buncombe County's been doing it differently than Smoky. We have been getting some good services, and I've said that many times. Smoky is going to do it different from October 1st. We are going to get the effect in a negative way in the future if we don't step up and say we need to do it differently. So I'm just putting it on the map that I ain't gonna let them stay in the closet, because they have done things in the dark and in the secret, and now we're getting them in the light. So, thank you very much.
Just clarify, MCOs meaning LMEs or area authorities, mental health providers. Jim is not sticking with that, does not have $40
Thank you, Jerry. Thank you. Anyone want to bring anything else up?
We did it.
If not, do I have a?
Excuse me, so this is vacation time of the year, and I don't know what your poll found about that. And how's that gonna affect next month, which July is the biggest month for vacations?
Yes, Krista put out a survey, and she's on vacation this week, so I don't know what she found, but my guess is, judging by even the challenges we have today, that July will be a tough month for individuals. I will make sure she gets something out on Monday when she gets back. One of the pressures we feel, and we talked about this last time, is there are a lot of interesting panels we want to bring and real-time subjects y'all are interested in, and then there's the orientation about what actually sits in health and human services. I'm fine with moving more, keeping on with the issues that interest you than the basic orientation, but for accreditation, we have got to get through public health orientation for the board members who haven't been through it. Gibby could put out a poll about whether those individuals would rather go to a different meeting to do their orientation or do it online rather than using a whole board meeting for that, if that's helpful to people. Because we have a lot people are interested in us bringing, and then we haven't done orientation about how big the scope is you're really responsible for.
Okay.
So
I understand.
we'll put surveys out on both those things.
Dr. Oliver, did you get your answer?
Yes,
Any other question? I have a motion that we adjourn.
Thanks, y'all.
So moved. Moved.
Second.
All right, thank you. Yep. You may go.